Thank you, everyone. So the last cases will be discussed by me only, the breast and ovary and the sarcoma. And I would like to invite one of the most senior oncologists in the town, Dr. B.K. Smriti Madam. Uh, we have Dr. Sampada Desai, a consultant surgical oncologist at Hinduja Hospital, Dr. Ravi Krishna from Hyderabad, Dr. Jayan Gawandesa from Pune, Dr. Birendra Yadav from Nepal, Dr. Akil Kapoor is there. Uh, like this is an exciting time in cellular therapy, and I think these presentations are being made in the front of the person who has made first cellular therapy, and there is no one else than Dr. Advani sir, because he is the first one to do a bone marrow transplant in India, and that is the way of cellular therapy. And I always still remember, actually I started my career as a, Dr. Prabhat Dharka, I'm sorry. I started my career as a stem cell transplant physician and then into the medical oncology. And that time, one of the oncologists told me, "Arey, why, transplant is a dying art." I said, no, transplant is a form of a cellular therapy. Only thing it is, it will come in different format every now and then, because what you are trying to do is, I think, immunity. And I think it's a privilege to be present, in the presence of the father of, I will say, cellular therapy, Dr. Advani sir, who is the first transplant physician way back in 1983, sir, if I'm not wrong. 1983, yeah. And Dr. B.K. Smriti madam. So with this kind of salvat, definitely, we will see that all these cases, they are, when we are looking at, probably we have reached the fag end. So this is a CA breast, a classical HER2 positive patient has received standard 6 TACHP surgery. She didn't have a patch CR, so adjuvant TDM was given. But within 7 months of TDM1, she progressed. She has received TDX. Again, progression in 8 months, desperately trying to, give K-PLEP. Again, progressed in 3 months. Patient was not willing for a clinical trial. She was also counseled for neratinib, tucatinib, but patient was not willing. I think I will ask B.K. Smriti madam, ma'am, how often do you encounter HER2 resistance in a practice? Like primarily or maybe?
It is a rare phenomenon today, especially given the number of options that you have. So the case that you're showing is one of the less common, maybe 10% falling into that group, who is just resistant to everything. I think within few months, because I can't read properly, I forgot my specs.
Yeah, yeah.
It's
So
within
these are
few
almost
months.
6 to 7 months. I mean, like
Yeah,
hardly
so I
she has
mean,
had into
yeah,
responses.
she's really very resistant to therapy. Yeah.
Anyone else? Dr. Birendra? So how often do you encounter like trastoma? Say now TCHP, though we are saying, but all cannot afford TCHP upfront. But how often you see a primary trastuzumab resistance or HER2 resistance in your practice?
So, very few patient you can say, otherwise patient do well on TCS.
Yeah. So I will not waste much of the time. So basically, we have discussed now some time back, HER2 TCR, and this is the patient was treated with the HER2 TCR. This was the before treatment on the left side. You can see this is before treatment. The patient has a massive pleural effusion, and the right side photograph is after treatment. And again, this was a liver metastasis, which was there, which is almost around 7 centimeter within the span of 6 weeks. This has almost reduced to less than 2 centimeters. So these are something excellent responses which were seen with the HER2 CAR T. Again, this is the same patients. Before we can see these are multiple liver mets, almost they are disappearing on the right side. So definitely we are having, yes, case selection is a must, and these are the expensive treatment. But what I just wanted to highlight here, despite of the fact, like there's a primary HER2 resistance was there, still this patient has shown a very excellent response. The next case is again ovarian malignancy. Yes, yes, ma'am. The patient is. See, she is now 4 months, ma'am. So next case is ovarian cancer. She is HRD positive. Like now all ovarian cancer definitely will be doing HRD as well as the BRCA. So she was HRD positive, TP53 positive. She has received 3 cycles of paclitaxel carboplatin surgery. The HIPEC was done, and again 3 cycles of paclicarbo. As she was HRD, she was offered olaparib maintenance. But within 3 months of maintenance, olaparib, she has relapsed, which was like non-salvageable, and she has received gemcitabine, carboplatin plus bevacizumab. Again, progression within 3 cycles. So she has received then single agent irinotecan, single agent lipodox, oral metronidazole therapy, endoxan, etoposide, and letrozole. So CA 125, 1345, and ascites was there, liver and bone mets were there. Patients otherwise has a performance status of 1 or 2. So what one can offer in this situation? Because she was HRD positive to actually begin with. Again, we have
Maybe taxanes, single agent taxane, paclitaxel.
okay, but there was hardly any response, within 6 months. Yeah. No, ma'am.
That's one of the new drugs.
Yeah.
Rituximab is one of the new
Yeah.
drugs now for ovarian cancer. The only issue is alpha folate receptor testing is not done in India,
Yeah.
so you have to send it abroad. So I think Tempus is doing that. They're doing combination of NGS and that. So that is one thing you can do, but the drug is expensive, so I don't know. And I think it's time to do NGS in these patients, though we were not using it so much in ovarian cancer. But it's time to do it now. I mean, you might find that, like in ARID 1A or something like that, they may respond to immuno or give immuno along with olaparib. So these are some
Yeah,
of the
sorry, her NGS
options.
was done, this as relapse, my bad. TP53, she only had just TP53 positive.
Only TP53.
TP53.
Yeah, so you didn't get ERB2 on
No.
NG. If you do an NGS, like I have a mucinous carcinoma, everything failed. Patient even had recurrent ascites every 3 weeks. And then we did a NGS. It showed ERB2, this thing amplification, and HER2 was 3 plus. So in that patient, she has responded very well to pertuzumab, trastuzumab with chemo. The ascites has disappeared, even the obstructive symptoms have disappeared. So it's worth doing NGS. And then of course the CAR T you will have to tell us. Because it's very experimental, I know
Yeah,
that.
yeah.
So,
Sampada, your experience,
because of the heterogeneity, antigen
Yes.
escape, all these things. So it's
Yes.
very, very investigational at the
Yes.
moment. But I think you can use MUC or one of these.
So how often you see, this HRD positivity BRC, those who are put on olaparib maintenance but really have very short DFI.
Very rarely, less than 5 to 10% of the cases.
So any other things, like you want to add?
So,
I mean, definitely this is a more of a
definitely
critical
not a
oncology.
definitive surgery for this patient, but she has liver and bone metastasis, and if she is not symptomatic and ascites is the only that is causing symptom in her, we can offer PIPEC in this case. A few settings that will control, but since there are liver and bone metastasis, it might not give you more benefits. It was only ascites, then it might have been controlled with PIPEC.
So how many patients of CORI, if they relapse, you are able to salvage them? Like you are planning a second cyto reduction. I mean, how many percentage in practice, or and you have any
Secondary,
criteria?
yes. We super select our patient because desktop 3, the benefit of secondary cytoreductive surgery is only in the setting if I can get a CC0 or R0 resection. So we super select our patient to the extent of we should get at present our more than 90% of our patients do end up getting a complete CC0 in a secondary cytoreductive setting. So only less than 20% of the patients which relapse must be coming on table for secondary cytoreductive surgery.
And I mean, definitely this should not be a very great question, but do you think, are you seeing that more of this may BRC or HRD, these kind of patients, do you know, I mean, you feel that they are better salvageable, or, they relapse pattern or
Usually
something
what is seen in the practice is that BRCA positive patient, they usually relapse they have a longer disease free interval, and they are the patients who come on table for secondary cytoreductive surgery.
So definitely this patient when has come to the clinic, she said she doesn't want to further go any chemotherapy or anything, and whether we have also given, as madam has suggested, biopsy, if at all we want, we can do NGS, and she was TP53 positive, so she was treated with TCR of TP53, and the dose was 4.5 into 10 raised to 7 on day 0 and day 3. She had a CRS grade 3 just in the terms of fever, chills, rigors were there, and she has ICANN of grade 1, with just little bit of confusion, but which was manageable. A very significant response, serological. The response which was seen on day 15, the CA-125 has dramatically come from 1, 2, 3, 4, 5 to 200, and almost after the follow-up, we are yet to do a scan in her. So I mean, yesterday only I had a follow-up with her, and ascites is almost resolved. Means the lady which was requiring ascites, yes, as Dr. B.K. Smith has pointed out, we have to be watchful in a view that all these therapies are newer, whether any escape is happening, and how durable are the responses, because we might are seeing these responses definitely, and her scan is pending in the first week of January, so we are planning a scan in the first week of January, around 6 weeks from the time of therapy, so that we'll know. But her performance status also has improved, like the fluid and everything is disappeared, so she is having better, the appetite is better, so let's see how she is going to respond.
You've been talking of so many targets for these cellular therapies. Now, P53 happens to be the most frequent in most tumors, and I think this is off the shelf, right?
Yes.
So,
This is not off the shelf, ma'am.
yeah,
This is a prepared.
prepared one.
Yeah, so this is basically, ma'am, these are the patient specific. This is, so we did the biopsy of the tumor, and then we take the T cells from the tumor, from the patient's blood. We send it to the lab. They prepared it. They do the again analysis of the tumor, and it's a patient specific. These are T
So
cells.
how long? 4 to 6 weeks.
Around
6
around
weeks.
4 weeks it took for the patient. So meanwhile, we have just given one salvage regimen in that. I've just given a lipodox bev, one cycle which was given, and 4 weeks gap was given, and then later on we. So last one is a 26-year-old male, alveolar soft part sarcoma, left eye with lung mets. He has received IFOS doxorubicin progression within 4 months. He has oral metronomic in the terms of pazopanib, again progression in 3 months. Docetaxel, again progression in 2 months. On NGS, there is no actionable mutation. Now, Prabhat, I think like we have a sarcoma specialist. How often you have some targetable mutation in sarcomas when you do NGS or any?
Very rarely. This particular case, I wouldn't have sent NGS also, because I know it is ASPS, then there will be a transfusion of the TFE3 gene, so nothing would have come on NGS otherwise also, so I wouldn't have sent NGS.
Yeah. So basically young patient, so what will be the options? Because these
Immunotherapy.
otherwise we can find, because sarcoma most of the times we realize, we are giving therapy after therapy, probably what we are having a best response, rarely partial response, but most of the times it's a stable disease, patient is well maintained, they come with the scans, now progression what?
I have started giving sunitinib with combination of nivolumab for ASPS because there is some data of immunotherapy. Till now they are doing good. We presented at Delos conference 2 or 3 patients. My resident won first prize for that.
Wow, great, congratulations. Ma'am, your take on this, definitely no cellular therapy,
Well,
but
as I said, sunitinib is as far as we get, and it's one of the worst sarcomas to have because it really doesn't respond to chemo. So I think one can move directly to sunitinib, and then this is some good data that he's saying that would combine it with immuno, because as immuno alone, it's not responsive. So I think the combination like would do in some other tumors, TKI with immuno.
Jen sir, your take on sarcomas, like, I'm not saying alveolar, but sarcomas, how many times really in different sarcomas we see a targetable mutation, working of
Very rarely. Very
How
rarely.
often, like, Prabhat, your experience, any sarcomas responding better to immunotherapy?
Post NART you can give immunotherapy and there is good response seen compared to only NART alone. So UPS and UPS and myxoid liposarcoma.
So most of the times we land up in this situation, sarcoma, these are the patients who will be otherwise will be there, and you don't know actually what to do. And again, this patient come with this, and this is autologous T cell therapy for A4 solid cancer in HLA-02 patients, which is a phase 1 trial, and that's a shown. So there is a near and complete. So this patient has received. So there is a near and complete metabolic and morphological regression of the neoplastic soft lesion in the left lower thigh muscles. There is reduced activity, also sclerosis of this. a significant decrease in the metastatic bilateral lung nodules and residual. So this patient is now 3 months post therapy. Let's see like how long these therapies are remaining basically, because as madam has pointed out, this is something which is investigational, so definitely we cannot push for, but when you are actually cornered, maybe we can offer the patient, but till time will tell us how durable these responses are going to be, because I think we have attended lecture, they have said this is a one-time therapy, as compared to when we are saying the standard immunotherapy and other things. But I think there are certain scenarios where I think we yet to explore, but only thing is that this is exciting time in the immunotherapy bracket. I think this can be just one of the arbitrary. I would just like to have like one final comment from all of you.
Agreed. Adding one more armamentarium is beneficial, as I was there as a panelist in GI also, or in this such cases where we are in solid tumor. It used to be that we are doing palliative therapy most of the times. So even if it adds some years, months or years to patient's life, it is useful. Whether it will have a long-term response, that time will say. But even right now, few months or years that I've learned today is beneficial for patients.
Well, at least in gynec malignancies, as I said, ovarian is investigational, but it has been approved for cervical cancer. So I think that's where you have to see. And of course, endometrial, it would be investigational because you already have immunotherapy and immunotherapy combinations. And in breast, we have so many options. So I think it would come much later down the line, and maybe more in HER2 positive and in those small subsets who are, resistant. So, I mean, that's where I would place it.
I mean, any worry or do you feel any safety signals will be there in the future? Like, most of the times when we are using this therapy, second malignancy or anything like that.
In which condition?
No,
Ovarian cancer?
No. I'm saying using these cellular therapies leading to secondary malignancies.
When they have already received several therapies, we really don't know whether the incidence of second malignancy is due to the multiple lines of chemo or the cellular therapy. It would be difficult to distinguish. I mean, it happens with ovarian cancer. You use olaparib down the line, previously. So they said increased MDS, this thing. But was it due to the multiple lines of chemo or just due to olaparib? It's difficult to say.
Sampradaya, your take on cellular therapy definitely is wrong to ask to a surgeon, but still.
I think it is worth it in trying in patients where all the lines of chemotherapy have exhausted, and I hope it starts working, especially for ovary.
So yes, this cellular therapy is emerging. So yes, if you are finished with everything, so you can still try, and let's see the results how it will come. Yeah.
Yes, and definitely when all the options are exhausted and finances are not a constraint, definitely push for the new therapies.
Yeah, fingers crossed right now. We have to wait for long-term data, but definitely you should keep it in your mind that this could be an option.
So all the recurrences are intraperitoneal. So yeah, are you looking at some sort of cellular therapy which could be introduced intraperitoneal? Like you said in GBM, you give intraventricular. So I think that is one thing that should be explored in ovarian cancer, because even the most recurrent, it's very rare that you would get metastasis somewhere. It's mainly intraperitoneal.
So your point is very well. In fact, in GBM, intracavitary has come, and so they have started exploring it in CEA CAR-T. CEA CAR-Ts. CEA CAR-Ts have been explored intraperitoneal, but we don't have up till now phase 1 data of someone exploring these CAR-Ts in ovary. But what your point is correct. It will come definitely as we get more about this.
I mean, you have CA125 as an antigen there. So, CA125 CAR-T, something
Yeah, it's point well taken, ma'am. Yeah.
I think thank you very much, panelists, and I mean we cannot end this. I think I want final comments from the father of cellular therapy in India.
Yeah, well, I think the whole whatever we have listened today and whatever we have been looking at it, it appears that just like initially we had surgery, radiotherapy and chemotherapy. Then we got the two therapies, target therapy and the immunotherapy. And they were really transformation in the medical treatment of the cancer. And now I think the cellular therapy is going to transform the whole area, that how we can target the tumors in the subcellular fraction. I think that is what is important. It's not only the surface protein, but what is there inside also. And focus. So I think it's an exciting time. The data, more data has to come. And I think once the data gets consolidated, I'm sure they will still become a sixth standard treatment.
Thank you very much. So there are a lot of students in the, so just understand this workshop was just an exercise to know what are the newer things that are happening. That is standard of care. Do not write in the paper that I will send this patient for adaptive T-cell therapy or whatever. So the most important thing is that we should know, what is happening. So this is not. So even if you look at the NCCN guidelines, these things won't be there. But you should know what is happening around. It is not, because we always say, if you are just concentrating, because now I think the era has changed.
But this will be a question in examination.
नहीं, वो तो gold medal का question होगा सर. Gold medal का question होगा सर, लेकिन पहले आंसर दिया तो फिर तो फुलन हो जाएगा. So thing is that what we are discuss all these things where you are absolutely pushing the corner. The patient selection is most important. Again, as a senior oncologist like Dr. B.K. Madam is saying, sir is saying, we need a more data. Yes, definitely how the data will be generated when we are treating more and more cases and we are getting more and more confidences. Definitely, but we have to look at all the standard therapies, we have to understand the biology. Definitely this is a new beginning, but yet to get a lot of data, and I think the future is only thing is brighter in the terms of cellular therapy, and maybe we are just slowly moving away, but that doesn't mean that chemotherapy is gone forever. It's still there, still standard of care. Immunotherapy has come as a now we are seeing different head and neck is there or lung is there, which is come in the neoadjuvant setting. Even breast triple negative, we are using neoadjuvant immunotherapy. So I think it is going to change a paradigm shift, but still then I think we have to remain updated. Thank you very much.
And I
Thank
have
you
just two last questions.
Yes.
One thing is, what is the cost factor
Yes, yes.
involved now since you are doing it in India, and you are getting the source from local sources. So I just want to know what's the cost involved.
So Vijay, you want to answer that? Not local sources.
Ma'am, I think that it is not coming from local sources. Our GMP manufacturing unit has started building up. By June or July, we should have the inspection from DCJ, and then the manufacturing will happen local. At present, we have partnered around 15 labs globally. So the BCMA comes from California for us. A few of this come from Wiesbaden, Germany. Few of this come from Israel. Few of this come from Beijing. Few of them from Zhangzhou. Few of this come from Malaysia. Few of this come from Singapore. So the cost completely differs from which lab it is coming. The cost can be as low as 50 lakhs. It can go up to 1.2 CR depending, because sending it across the Atlantis is very costly, and getting it across the Atlantis is very costly. And how much is the cost? There is an import duty on it and there is a GST on it. So the product cost skyrockets. But the thing is, I had actually initially when we had counsel, I'll tell you a story of one of the patients. The option was to do this here. The option was to do this in MD Anderson in a clinical trial. In fact, I told him, you do it here, you will have to spend around 70-80 lakhs. Why don't you go to MD Anderson and do it? The patient after 2 months and actually scolded me like anything. The patient ended up spending 1.8 CR in MD Anderson. Till he reached the clinical trial itself, that much money was exhausted, and staying expenses and everything were others. But we feel that once the manufacturing starts here and there are clinical trials, we are waiting for the DCJ to give us the clearance for that. After that, I think the cost will come down substantially down in India itself.
Yeah. So I think in solid tumors as opposed to hematologic malignancies, I think the duration is very important. I know that we are offering it way down the line. Maybe a little ahead it may work better. Till we have the data of actual, what is the median survival, or even, I don't know whether we can talk of PFS. And what do you say from your experience in solid tumors till now? with
I think
these
they just have
therapies?
6 months
Is it
experience.
just stable disease? Can you talk of PFS or what?
Ma'am, up till now we have done 48 cases. The reason, ma'am, up till now we have done 40 cases, but we started only in June, ma'am. So it is not even 6 months, and that's the reason why we did not show our data. We are analyzing our data, and you will be seeing we are presenting our data in ASCO this year, which will be for ICANN and. But for the survival outcomes, we'll have to wait for the end of 2025 to come. I think that is the time things will be more mature to talk about.
At this point of like any phase 1 therapy, the response rate may be the surrogate endpoint at least for that. So the only thing is that when the options are nothing and patient want to do something for that, at this point of time they have to go outside search money. So at least we have an option, and at those who can afford, knowing the nitty-gritty of this subject, that options are limited, it's not a very standard of care, but someone wants to try, at least we can have an option in India to send those patients.
Thank you, panelists. Thank you.